Hello and welcome to GP Notebook TV. My name is Anish Kotecha and I'm a GP in South Wales. Today I'm going to discuss with you the BMJ article that was published on the 11th of August 2020 that covers the management of post-acute COVID-19 in general practice. So in essence what I'm going to do is I'm going to give you some quick updates and some key take-home messages that I believe are important for us in general practice. So let's start with some definitions. Post-acute COVID-19 is usually when symptoms extend beyond 3 weeks, and chronic COVID-19 is when symptoms will persist beyond and are ongoing past about 12 weeks. Now we know that the majority of patients will recover spontaneously with rest and symptomatic management from COVID-19. About 10% of patients will have a more prolonged illness, and these patients are usually divided into two categories. Number one is when they have some serious sequelae, and number two is when they have a more non-specific picture. It's really important for us in primary care not to over-investigate some of these people, because a lot of the time self-monitoring and looking out for red flag symptoms is all that is really needed. We need to be pragmatic in our approach to this as well. Now, the article suggests that although we don't know exactly why some people have a more prolonged illness, some contributing factors might be a persistent viremia from maybe a weakened antibody response, maybe reinfection or deconditioning can be an issue as well. So what are the kind of things that patients might come to us with? Common ongoing symptoms are things like chest pain, shortness of breath, fatigue and an ongoing cough, and other patients can come with headaches, dizziness, neurocognitive difficulties, mental health issues, muscle aches and pains, and we know that gastrointestinal upset can be an issue, and also skin rashes. So a whole host of symptoms and a really wide variety. So we need to be on the lookout and think about some of these things and whether they're actually post-acute COVID-19 rather than other illnesses. I wanted to mention three specifically, if I may, at this point. Number one is the cough, number two is the fatigue, and number three is shortness of breath. So the cough can be fairly persistent, and here we know that breathing exercises can really help patients. We need to think about whether reflux is a potential issue, and if it is, then adding a proton pump inhibitor, for example, can be helpful. Otherwise, just simple treatments like honey and codeine linctus may be all that is needed. Number two, fatigue. So this can be a really frustrating symptom for a lot of patients, and it can be quite prolonged. Here the importance is to reassure patients that this should get better, although it might take some time, and a gradual increase or reintroduction of exercise is what is really important here. But of course, reminding patients that they can come back to us if they need to. Number three, the shortness of breath. Now, what I've done here is given you some key bullet points which I think are important to think about when we are assessing and managing some of these patients with persistent dyspnea. This can persist for quite some time. We know that silent hypoxia is an issue in acute COVID-19, which is why, of course, if we're concerned about patients, that then measurement of oxygen saturation should form part of our assessment. We also need to be mindful if we think a patient might have a bacterial pneumonia or even a thromboembolic state. Patients having access to pulse oximetry at home can be so helpful. And if levels are normal, then this can often add a layer of reassurance for patients and, of course, ourselves. We know that assessment and management of patients with ongoing shortness of breath is really important. So let's talk a little bit about the complications of acute COVID-19. I wanted to break this down into three if I'm able to. Number one, we know that about 20% of patients will suffer with fairly serious cardiac involvement, and unfortunately this will include the previously young and healthy population. Now, the key priority here is to distinguish those with likely musculoskeletal and non-specific chest pains to those with more serious pathology. And if, of course, we have any doubt, then we should be recommending an urgent cardiology review or opinion. Number 2, we know that acute COVID-19 is an inflammatory and hypercoagulable state, and therefore we have to have a really low index of suspicion for thromboembolic states and conditions. Unfortunately, the problem is we don't know how long this risk will continue after the acute infection. So we need to be really mindful of this when we're speaking to our patients. Number 3 is the more non-specific neurological type of symptoms, things like headaches, dizziness, and what patients will describe as brain fog. Now, as long as we have talked about and ruled out the red flag symptoms here, sometimes all that is needed is reassurance in asking patients to manage themselves at home, but of course keeping the doors open and asking them to represent and talk to us again if they get more concerned or any new symptoms develop. Now, unfortunately, we all know this, that COVID-19 is disproportionately affecting our elderly population with the more severe end of the spectrum. And this is really unfortunate because the elderly population are being left with delirium, chronic pain, and also depression. And this adds to the already huge psychological impact that they've already got through difficulties in accessing healthcare and also social isolation. So having a really holistic approach to care and trying to ease access for these people is really, really key and really important for us. I wanted to make a specific point of mentioning mental health issues here, because we all anecdotally probably realise that we're getting lots more phone calls about people's mental health states at the moment, and lay accounts are suggesting that there is an increase and there is a much more common problem of people suffering with things like anxiety, depression, helplessness, feelings of hopelessness, and also post-traumatic stress disorder. And this extends, unfortunately, to healthcare professionals as well as patients at the moment. Now, although a small proportion of patients might benefit from referral to mental health services, patient organisations are very keen for us to advocate to patients the importance of well-being, thinking about mindfulness, self-care, and also looking at peer support and the importance at this time of social connection. And we need to really be talking to patients about the importance of these things at this time. Also being mindful that people that have had COVID-19 might have also had family bereavements, they might have experienced job losses, they might have financial stresses, and this is adding to the really burdensome time we've got at the moment and the huge strains that people are feeling with lockdown during this pandemic. And really just being mindful of this is important because it just allows us to support our patients in whichever way they feel they need to access our services or even just talk to us over the phone. And this can be very holistic for them. Now, how do we support recovery? Well, we know that the majority of patients will recover within about 4 to 6 weeks of acute infection. And often all that is needed is things like paracetamol and non-steroidal anti-inflammatory medication for symptomatic relief. Talking to people about gentle reintroduction of exercise and aerobic exercise as tolerated, and even thinking about a phased return to employment can often be fairly helpful. So, in summary, unfortunately, post-acute COVID-19 can have a very prolonged effect on a lot of our patients, and I think in general practice the key take-home message is really to witness the patient's story. That might be very prolonged, it might be very uncertain, and it might not fit easily and obviously into an obvious medical explanation. A lot of the time all that is needed is monitoring of symptoms by patients at home, but often to remind them that we are here, and we should make it as easy for them to access our services as possible as we embrace the new way of consulting over the phone and even through video. So thank you very much for watching this video, and I hope you found it useful. Please tune into GP Notebook TV for further videos like this one. Thanks very much.